Good morning. I'm Haley Daigle. I'm the Bariatric and Minimally Invasive Fellow at University of Tennessee, Knoxville. I want to thank SAGES for giving us the opportunity to present our project, Fighting the Obesity Pandemic during the COVID pandemic. I have no financial disclosures. Surgical volume everywhere has been affected by COVID-19 due to staff shortages and hospital bed availability. One of the patient populations at increased risk of death from COVID-19 is the population with obesity. Improvement in surgical techniques and perioperative care of the bariatric patient has decreased morbidity and length of stay of bariatric surgery from 5 days down to an average of 2. And many institutions are routinely sending patients home on post-op day 1. To continue getting our patients the surgery they've been working towards and improve their overall health, we designed a pathway to allow our patients to safely undergo bariatric surgery outpatient. We selected patients who were low risk based on OSMR and other comorbidities. We taught them to use a pulse oximeter and record their heart rate and oxygen at home. Intraoperatively, we used a bariatric ERAS protocol to minimize pain and nausea. Postoperatively, we monitored our patients in PACU for 4 to 6 hours. They received fluids, pain control, and antiemetics and had to tolerate 4 ounces PO before discharge. They were sent home with a pulse oximeter and were instructed to monitor their heart rate and oxygen every 2 hours while awake, and were given parameters for which to call their surgeon. Additionally, they received a call that evening from their surgeon to check on them. They returned to clinic the next day and were given another 2 liters of LR, and their labs were checked. We performed a retrospective review of the patients that we selected to undergo outpatient surgery. As with most bariatric centers, our patients are mostly female and our average age was 42. We do more bypasses than sleeves, and this was reflected in our study population, and we even did a few revisions outpatient. About 90% of our patients were successfully discharged home on post-op day 0. 10% were admitted from PACU, most commonly for uncontrolled pain or nausea. There were 3 readmissions within 30 days. 2 of those were discharged home on the day of surgery, and 1 was discharged on post-op day 1. There were no significant difference in readmission rates between the 2 groups. We looked at the comorbidities of patients who failed to discharge on the day of surgery to see what changes could be made to our selection criteria to better predict who would be suitable. There was a statistically significant difference in average BMI, with the admitted group having a BMI on average 5 points higher than the discharged group. We recognize this is a retrospective review of a single institution, which is a high-volume bariatric center of excellence, and our same-day discharge may not be equally safe at all institutions. We had no morbidity that would have been prevented with a post-op admission, and no mortality in either group. We demonstrate that by selecting low-risk patients and implementing at-home monitoring of vitals, we were able to safely perform outpatient bariatric surgery.